Hello, and welcome to another edition of Turnover Time. I'm Erica Biscard. I'm the Vice Chair of Online Learning for the Associate Membership, and I am joined today by Dr. Zach Holly, who's a PGY4 resident at Prisma Health in South Carolina. And our featured author today is Dr. Hachimanji, who is a assistant professor of surgery at the University of Chicago. And today we're featuring another one of our SACO Scholarship winners. Again, the SACO Scholarship is available for AAST associate members, and you get several benefits. You get your fees for publication waived, and you get one-on-one mentorship in any publications that you're preparing. And then you get to sit down with us and have a feature on turnover time as well. So it's a great opportunity, and you all should apply. Today, we're going to be talking about the paper Reboa in Shocked Penetrating Abdominal Trauma Patients, Impact on Outcomes.
So the author's hypothesis was that using Reboa in the setting of a penetrating abdominal trauma patient who's in shock would delay time to laparotomy and ultimately result in increased mortality. This was a retrospective review of the TKIP database from 2017 to 2021. It included trauma patients over the age of 16 years old at level 1 and level 2 trauma centers who presented in shock. Now, shock was defined by initial ED systolic blood pressure less than 90. They had to have penetrating abdominal trauma, be it gunshot wound or stabbing, and ultimately had to result in a trauma lap. The primary outcome of interest was in-hospital mortality, followed by a number of the secondary outcomes you see here. After exclusion criteria was met, there were approximately 148 patients who had Reboa placed prior to laparotomy. In an effort to quantify the effect of Reboa on the before-mentioned outcomes, patients were propensity matched. This worked well, and there were largely no differences in characteristics of the two groups, as seen in the table to the left. So let's review the results. In the propensity matched cohort, the use of Reboa was associated with an increased use of red blood cell, plasma, and platelet transfusion volume in the first 4 hours. Reboa patients also experienced statistically higher rates of extremity compartment syndrome, leg amputation, and a 10% higher in-hospital mortality. They also noticed that those who had Reboa prior to OR experienced significant delays to laparotomy incision by about 10 minutes. In conclusion, Reboa use in penetrating abdominal trauma patients who are in shock was associated with slower time to the OR and larger transfusion requirement of blood products, more leg amputations, and increased inpatient mortality. So I thought this was a really helpful article. Thank you for joining us today. I'd like to give you the floor now, a few questions. What inspired this work?
Thanks. That was a great summary, Zach. And thank you both for having me here to do this. In terms of what inspired the work, I think maybe it's sort of an obvious thing to say, but Reboa is sort of a hot topic. I feel like it comes up. It seems like at every meeting, it's a topic of conversation. It's pretty common to pick up one of our journals and see something about it. And so I think it gets discussed a lot. I also think that a lot of the evidence so far, at least a lot of the early evidence, had to do with Reboa versus ED thoracotomy, which to me personally, and I recognize that not everyone's going to share this opinion, but to me personally, it always sort of seemed like the wrong comparison to make because I think, I felt like there probably aren't many pulseless patients that should get a Reboa, and there probably aren't many patients with a pulse that should get an ED thoracotomy. And so I that always struck me as a little funny. But I did think, well, what about these patients that are not pulseless but in extremis? Does this help you sort of temporize and give you an advantage while you make your way to definitive hemorrhage control? And I know that I'm not the first person to ask that question, and I don't mean to suggest that, but Anecdotally, I started this work when I was still in fellowship and at a place where I saw people doing this in this population in penetrating abdominal trauma patients, on the way to the operating room, and I sort of was like, I'm not sure if we know if this is a good thing or not, and so that sort of led me to go ask the question.
Okay. How did the scholarship help with this work?
The scholarship is great, and I'm grateful to have received it. First, from just sort of a practical perspective, as Dr. Biscard mentioned, it sort of opens the door to be able to submit the work to SACO, which I think is a wonderful journal. Um, uh, but if you're somebody that doesn't have a lot of financial support, having to pay for it can be a bit of a barrier. And so, just from that perspective, that's really wonderful to be able to do that. But on top of that, getting the mentorship and the feedback from people outside of my institution or from my co-authors is really, really valuable. I think, I had great mentors in training. I have great senior partners now. They give me a lot of good advice, I think. But I think if you work with the same people over and over again, you sort of, what they're going to say to you. You sort of, you're on the same wavelength. And to be able to get some external feedback from some other people you don't work with all the time is really valuable.
Great. So then what are the next steps for your research?
Next steps, I think any good sort of clinical outcomes research questions should be driven by uh, um, questions that come up in real life care of patients and things that you think are going to help you take care of people in front of you day to day. And therefore, I think should be sort of a product of the environment in which you practice. And as I sort of alluded to, I started this work while still in training at a place that used Reboa with some frequency. I'm now at a place at the University of Chicago where we don't use it. We don't have any. Um, and so I think I'm probably a little off of the Reboa thing. But we do, we're a sort of unique place in terms of the high volume of operative penetrating trauma that we see. So I think that opens the door for us to ask some more questions that are relevant to sort of similar populations, I think. I'm fortunate to have formed a little bit of a research group at the University of Chicago where we're asking a lot of this stuff, and you know, hopefully you'll see some of it at upcoming meetings and see some of it in print in the near future.
That's great. Thank you so much. We'll continue the great Reboa debate, I'm sure. Well, again, thank you both for your participation. Thank you all for joining us for this edition of Turnover Time. We look forward to seeing you for the next.